Broadcasting live from the Business Radio X studios in Atlanta, Georgia, it's time for CEO Exclusive, brought to you by Anona Enterprises.
Good morning and welcome to CEO Exclusive, where we get emerging trends from CEOs and their most trusted advisors. I'm your host, Soyini Koch. Many of you have certainly been aware of the many changes that are taking place in the healthcare industry. One of the most important is the shift to paying for value versus paying for volume. For those of you who are not familiar with that term, what it means is that people who are providing healthcare are going to be paid for the quality of the outcomes for their patients versus simply being paid for the number of patients that they see. And it's a huge and very sweeping change that's happening in healthcare. And on today's show, we have guests from AG Rhodes Health and Rehab who are experiencing and adapting to this change, specifically in the long-term care industry. So welcome to the show, gentlemen.
Thank you.
Thank you.
So we have Al Blackwelder and Deke Cateau, the CEO and COO of AG Rhodes. Start off, gentlemen, by telling us about what value-based payments actually means for you in your business, for listeners who may be unfamiliar with that term because they're not in healthcare.
Hospitals drive our admissions to skilled nursing and subacute rehab. And in order...
So I'm going to, for people who don't know what that means, tell us what subacute rehab means.
After a hospitalization, there are a number of places to go for after discharge from a hospital. One is home. That's the ideal. Two is if you're not ready to go home, or you don't have the availability of what you need in order to recover at home, then you can go to some other places, and they can be from very, very acute places like other hospitals that will keep you for a longer period of time, all the way to subacute rehab, which is not acute hospital, it's below a hospital, but it's rehabilitation that can be fairly intensive, but it's all geared to getting you ready to go home again. And so subacute rehab is one place where our admissions are driven from hospitals. Hospitals are very interested in getting their patients discharged quicker and consequently sicker. You don't stay in a hospital and just get well. Hospital does its acute business and then they discharge to a facility that can continue the recovery. So the hospitals are very much interested in quick discharges, and also very recently, hospital payments to the hospitals are contingent on how that patient has done after they leave the hospital. So suddenly hospitals are very interested in what their patients are and how their patients are doing after their discharge. That has not always been the case. In fact, it has for decades and decades and decades. They left the hospital and the hospital washed their hands of that.
Yeah, thank you, pay your bill, bye-bye.
Bye-bye. Not anymore. The hospital actually is paid on how well they do after discharge.
They being the patient.
They being the patient. So hospitals have become very interested in our results, in how we take care of patients, and
because now it affects
their payment stream,
right?
And that causes several things to happen. One, not just an interest in what we're doing, but a need to, on their part, on the hospital's part, to follow our quality indicators. They want to know quantitatively how we are doing. What are our results with their patients? And this is different for us. We have not always been focused like that. We are now. And so we have, we follow our own metrics of things like, how often do we readmit to a hospital? Because a readmission to a hospital is a direct ding to a hospital now. Mm-hmm. It didn't used to be before. It's just another admission. Touchdown. Not anymore. Now that readmission to a hospital cuts into their payment, into the hospital's payment. So we monitor how many readmissions we have. We monitor infection rates. We monitor things that are going to slow discharge down, urinary tract infections, ulcers, skin ulcers, and also the ability of the resident to function without psychotropic medications. And these are all things that can impact the not only the quality with respect to how long they're in the hospital, but their quality of life afterwards and how well they recover. So now it is, hospitals are very interested in this.
And Deke, how have these new metrics changed the way that you operate to the extent that they do?
Well, AG Rhodes has operated firstly in the Atlanta area market for a very long time. We are one of Atlanta's oldest nonprofits. We've been around actually since 1904. As skilled nursing facilities are what most people know as nursing homes. Our two main lines of business, which is typical of most nursing homes, is, as Al described, subacute care. But then we have a much larger area of our business, which is long-term care, long-term or custodial care. We have seen definite trends towards value-based purchasing, where the subacute side line of our business, which is also the line of our business, which it's a lucrative line of our business, has taken full prominence. It's caused us to partner much more closely with the Atlanta area hospitals. So our Cobb campus, which is the best example, I think of that just about, I think 3 or 4 years ago, started a key partnership with Wellstar Hospital, where we are actually serviced by Wellstar physicians. And the exact quest is exactly like you said, quality over simply services, over simple metrics. So these physicians follow our residents of seniors very closely. And a lot of this is reported back to Wellstar Hospital, and the resident, the senior, is tracked throughout the long-term care continuum.
So back up and philosophically, do you think that this is making people healthier? Do you think it's actually working? So is it, from your standpoint, is it actually improving people's health? And is it actually bringing costs down, which are the two, I think, philosophical principles on which value-based payments was based and brought into the market?
Well, first, I'll say I think the idea of value-based services are still in its early phases. So I think there's arguments both ways as to whether it is actually taking costs down. We at AG Rhodes have taken the mantra for a few years now that we want to be in the business of helping people to live well. And we have found that the clinical side, the medical side, which the hospitals most often promote, in our opinion, does not necessarily equate with living well. So we have been moving towards a less medical model of care in taking care of our residents. Al?
Well, that's exactly right. We actually come from a long history of medical care. AG Rhodes is built on a model much like a hospital. And that's the way it was for 120 years of caring for people that can't take care of themselves. You treated them in a hospital-like model. And that's skilled nursing that we all know, nursing homes. Long corridors, rooms off that, nursing home or nursing desks, uniforms, it's skilled nursing. That is not the best way to take care of our largely elders. It's not as respectful. It is more about taking care of the efficiency of the organization. It is efficient to line patients up. Everyone gets up at a certain hour. Everyone has the same meal at the same time. Medications are delivered one after another by a cart that rolls down the hallway.
That's kind of depressing.
It's terribly depressing, and it's not respectful. It is. It's not how any of us would want to spend time recovering. So we are approaching this from a different point of view. In Europe, for instance, our industry in some pockets in Europe developed not from the medical part of when they were looking at how do we take care of our elders. We turned to the hospital industry. They turned to the housing industry, and so their nursing homes are residential. They're more house-like.
Yeah. And we had some guests on the Isaacsons.
Yes, perfect example.
That are starting to create that household model.
Exactly. And the Isaacsons are doing exactly that. And they are masters at doing this. And they're coming at it from the housing point of view. These are people who live independently in their homes. They decide, as we age a little bit, we're going to move to a place that can better meet our needs as we age. And so we are moving from our home to another home. That's like a home. It's a community. It's centered around our needs. We pay for things that we want and need, and these are centered on us. We, on the other hand, are coming at it from the other side of the continuum. We come from a medical model. Our residents have come from hospitals. They are ill. They can't take care of themselves, and we have been steeped in this medical model, and now we want to move this to a residential type model. It's quite frankly a little more difficult. We're not used to thinking in terms of living well as opposed to recovering from disease. And we are finding that the evidence is pointing from other places, because we're in the middle of doing this, that people actually recover faster, better, when we approach their recovery not as a model of medicine, delivery of medicine on schedules, efficiency, but more on what are your needs. An example might be someone comes from a hospital. Do they need to get up at 6 a.m. so that breakfast can be served at 8? Probably not, if they don't want to. But efficiency would dictate that, yes, everyone gets up, everyone moves in lockstep through our system. But the resident might want to say, let's skip breakfast this morning. I'll go to the gym at my appointed time to work out and get my physical therapy, my occupational therapy, my speech therapy. I want to be there for music therapy, which we have, and I want to participate when our horticultural therapist comes through. These are things that interest me, but I do not want to get up at 7 o'clock in the morning, and so let me be. And that is the sort of thing that we can work with. And being able to tailor therapy to your interests. For instance, there are a lot of people who are oriented towards music or oriented towards plants. Maybe they're gardeners. Maybe even they come from an agrarian family. And the idea of part of their therapy being working with plants is actually a good thing. Occupational therapy, fine motor skills, working with plants and repotting soil and repotting plants in new soil, all the way to large muscle movement of carrying a wand and using way over your head to spray and to water plants that are in the greenhouse way over their head. It's fun, but it's also rather therapeutic and with specific therapeutic goals assigned to them. We don't get paid for that. That's just something that we do because it's the right thing to do for specific residents.
So a question for you there. When we were talking yesterday, one of the things that you mentioned is that a significant portion of the population you serve are people who can't necessarily afford their own care.
That's correct.
How does that work with the trade-off between trying to make their experience more comfortable and these efficiencies on which a large part of your industry has been built?
The 80%, no, it's not bad. It's about 75 to 80% of our residents are actually Medicaid beneficiaries. And these are people who do not have the resources to live on their own, especially having to need assistance in all the activities of daily living. And the Medicaid program doesn't pay for the expenses of taking care of a Medicaid long-term care resident. Just doesn't cover it, much less the things that we offer our residents, such as music therapy or activities offered by in the community. Doesn't pay for that. We make up the difference in two ways. One is our short-term rehab Medicare residents that are there for less than a month. We actually do make a margin on those, and that margin offsets the losses in Medicaid. But probably more important is the generosity of the community, who understand that taking care of people who can't take care of themselves is noble work, especially those who don't have the resources to do this right. And people actually give funds to us to cover the cost of care for others. That's a remarkable thing, and we live in a very generous community. It's also very important, especially in light of the uncertainties in our Medicaid funding. Yesterday, the House passed a bill that could theoretically threaten that. We live in times where sometimes our revenue down the road may not be as sure as we would like for it to be. It's more difficult to plan. But our mission is to take care of people who can't take care of themselves. And that mission drives whatever we do. It's just the way we roll.
Great. So listeners, we're talking to AG Rhodes Health and Rehab, their CEO, Al Blackwelder, and their COO, Deke Cateau. I want to turn the conversation to talking about the people side of your business, and your business is very much a people business. Every single CEO that we've had on the show has said without exception that it's their team and the people who work for them that make their company successful. So what have you learned about having a great team from your experience at AG Rhodes?
AG Rhodes, for me, and I started at AG Rhodes just about 8 years ago. And the first thing that really caught my attention was the longevity of the staff. I had never seen nursing facilities where staff had been there for 40 plus years. So I knew something was different there.
Wow.
Yeah, exactly. And as I got into the management side of the business, it became clear and became evident. From our boards, we still have that family-like approach to taking care of our staff. And I say this not in a cliche fashion at all, but there's a reason that we have some of our facilities as low as 15% turnover rates in an industry where you have 70 to 80% turnover. So it is a true investment in staff. More importantly, it's an empowerment on staff. So what we try to do, and we've really been actively doing this over the last few years, we try to break down the bureaucracy of leadership and empower staff at the lowest levels to make decisions. And it's just a simple philosophy. Us taking care of our staff enables them to take proper care of our elders. And it trickles down and into every facet of our operation.
Let me give an example of that. And it's an historical example, but it sets the pace or the tone for this organization. And that is this cliche that I'm going to get very specific on you. This cliche, if you take care of employees, they will take care of our residents.
Yeah, the single biggest corollary of customer satisfaction is employee satisfaction.
Right. Exactly. In the 70s, when this was a relatively new experience to have nursing homes funded by the federal government, the Board of Trustees
for AG Rhodes,
the Board of Trustees made a decision. They said, look, taking care of our employees will make it so that they will take care of our residents. Okay, let's act on that. And so what they did was they did two things. One, they offered health insurance for all their employees. Now, in the nursing home industry in the 1970s, that was unheard of. It just didn't occur. And so, quite frankly, at that time, they paid the full premium for health insurance for their employees. Absolutely a radical departure from the way nursing homes were run then. And then they did something else. They created a retirement plan for employees. And it was not an employee contribution retirement plan. It was an employer contribution to a retirement plan. And so not only did they take care of employees with respect to short term, if you get sick, you've got health insurance, but also when it comes time for you to retire, you're going to have some sort of regular income. It was an old-fashioned retirement plan.
A pension?
A pension. It was unreal.
A pension.
That is just unheard of in the 70s. And so it's that kind of attitude and approach to employees that the Board of Trustees has kept all along. Now, we have not been able to pay the full insurance premium for our employees in a long time. Insurance is very expensive. We obviously still have it. We still have retirement plans. A lot of places do that. But now it is, how do we engage our employees into the care of specific residents? How do we create a sense of community and a sense of family within our organization so that employees, it's what they do. It's how they live their lives. It is taking care of our elders, short-term and long-term, in ways that are respectful. And to do that really well involves getting to know residents and paying attention to very specific needs that they have and trying to address and facilitate our residents living life well.
So how do you do it?
Well, Deke.
We embarked on a journey initially at our Cobb campus called a movement towards person-directed care, where Al did a very good job earlier of describing the sometimes industrial nature of our business. We have staff that our residents get up at between 7 and 8 a.m.
White walls, white sheets, white shoes, white clothes.
They have lunch at 12 and between 12 and 12:30. Shifts working 7 to 3, 3 to 11, 11 to 7. We have played with our staffing models and are actually starting to be able to meet residents' needs more specifically. So you want to wake up at 9 or 10 a.m. like I do, or so be it.
Not this morning.
No, not this morning.
This morning you had to get up a little bit earlier, Deke.
I have a great example of that that we saw with a resident who was up late. She stays up late at night, every night, at the nurse station. Loud music playing, loud television playing at the nurse station, and she's up. And I asked the question, what is she doing up? And the typical response in a traditional nursing home for someone like that would be Ambien, sleeping aid, a pill to help them sleep. Well, our nurses dug a bit deeper and they found out that this resident was up late at night because in her previous life, she was a night nurse. She worked the night shift. So they were able to meet her needs to allow her to stay up at night. Of course, she slept most of the day during the day, but how great is that? As simple as that might sound, it's not how we are currently wired in this industry. Currently we are wired, like you said, very, very regimented in everything that we do. The other thing that we have noticed, and this is from a very predictive model type, we have long known that a lot of the residents we took care of lived with dementia. We right now have about 50% of our residents living with dementia, and we estimate those numbers are even more. And we all know the silver tsunami in the aging population and the rise in cases with dementia. I think the latest figures I saw was 5 million people in the United States alone, and dementia is becoming the highest cost illness. So we are looking through person-directed care at better ways to take care specifically of people with dementia. And that is the model that we have been going at for quite some time. It fits our mission to take care of the most vulnerable of our elder populations. And right now, we can't think of no population as vulnerable as those living with dementias.
So you mentioned having like 15% turnover in an industry that has 70% turnover?
At one of our locations. So we have 3 locations. One of them runs about 15%. The other 2 run in the low 40s. But again, this industry, typically you see turnover rates in the high 70%.
In a year?
In a year, yep. Nurses, CNAs, clinical staff, they are in demand now. And we, as employers, have to have a product which compels them to stay with you. We think our product is that mission that we have. Al has a saying that he says that our staff are called to do what they do. There's a calling towards them, and that's what we try to avail for.
And so, if you have anything else that you haven't shared yet about how you compete, right? So somebody's choosing between AG Rhodes and one of the other 4 offers that they could get, or they have a recruiter or somebody who's calling to poach them, right, and take them away from you. What is it that has them stay?
Other than the obvious benefits that we spoke about earlier, we literally care for our employees and we empower our employees. So we do not want staff who come to us to be cogs and just stick to the task at hand. We want staff to come to us and build caring relationships with our seniors and caring relationships with our other staff. We've started to speak of care partnership, which is not just as simple as caring for someone, but it's working hand in hand. It's looking at caring as a relationship that goes both ways. So we want staff who are willing to learn from our elders as well as care for our elders. We are looking at intergenerational programs because we think that the younger folk have a lot to learn from our seniors. There's a reason they're still with us at 80 plus, sometimes 90, 100 years. So that's literally the type of staff we look for, and we are very selective. So it's a two-way street. We are very selective in the staff that we choose to bring into our communities.
I think it helps also that we have active relationships with schools that teach people the skills of daily activities and CNAs. And with an active relationship like that, then we get to pick and choose from the students as they are looking for jobs. Then we have more ability to select. And also, again, looking for people who have that sense of calling. This is what they want to do. This is how they choose to live their life of being with elders and helping them and learning from them. It is a relationship that we look for. We try and find that people have with elders, and sometimes that comes from people having taken care of a grandmother or someone who quit their job because they had to take care of a grandfather who had a stroke. And they sort of evolve their understanding that, wow, this is really wonderful work. It's hard work, especially when you know somebody. But if you're working with someone for over years, you do get to know them. But it can be extraordinarily rewarding. And we look for people who look for that, who look for the relationship that can be developed between themselves and an elder or a group of elders.
Great. Well, as we look to close the show, what are some of the things that are happening at AG Rhodes that you think our CEO listeners would be interested in knowing about? You mentioned, I think, perhaps a new facility, some new programs.
The staff training is always an issue and has been in my entire career in healthcare. How do you keep training people for new and things? And that is that's where we are right now. Is I don't want to say retooling because it makes someone look like a piece of machinery. But in a lot of ways, it is reorienting how we think about elders. And that is, it's changing our culture. And that's hard work. And it's something that is not a program. It's not something that's going to be done in 6 months with a series of lectures and books to read. It is something that is going to take years to inoculate, to allow to grow, to foster, to work with, to come back to. It's just going to take some time to absolutely change how we approach the care of elders. But I can't think of anything more important, especially as myself. I'm an aging baby boomer. I will not go to an institution like I have seen in the past. It's just no, not going to do that. It's important that we provide options for people that are much more respectful of our abilities as seniors. That we have much to contribute, and we can do it.
And I would advise innovation, and it's innovation has become sort of a C-suite cliche as well. But I'm not talking just about technological innovation, but innovation in programming. Our horticulture therapy program, our music therapy program, these are unreimbursed programs, which is why a lot of the for-profits would not look into programs like this. But they have been the most rewarding, and I think they've actually led to us getting admissions, getting residents from programs such as this. Aquatic therapy. So thinking out of the box in terms of programming. Now, as we see, as Al said, baby boomers coming into the nursing facilities, the days of the old activities programs, the
bingo,
the bingos, which again, don't try to take bingo out of any nursing home. You will have a fight on your hand. But I dare to think in a few years, the folks entering nursing facilities would not be the bingo players. I don't think I'll be visiting Al and playing bingo with him in nursing facilities.
You will not.
Yeah. So innovation is my advice.
Yeah, great. Well, thank you so much, Al and Deke. It's been great having you on the show. For listeners, we've been talking to the CEO and COO of AG Rhodes Health and Rehab, and they are a long-term care provider here in the Atlanta area. You've been listening to CEO Exclusive Radio. I'm your host, Soyini Koch. To get a summary of the key takeaways from today's show, you can find those on LinkedIn on our blog at 2:30 on Thursdays. And you can find out more about AG Rhodes at ceoexclusiveradio.com. I hope you have a prosperous, productive, and very profitable week. Thanks.
This show is brought to you by Anona Enterprises, where strategy is your access to money and performance. Learn more at AnonaEnterprises.com.